So our next speaker is Dr. Ramesh Dorairajan, heading the Sundar Eye Hospital, Chennai. And we are all aware that he does a great quality work and has been doing so with over 33 years of experience. And he is the right person to deal with this very difficult topic. On to you, Dr. Ramesh.
Can you see my screen?
Yeah.
It is seen? Okay, thank you. So my talk has two parts. That is biometry in atypical eyes.
Sir, can you go to the slide mode?
I started screen sharing. Can you see them? Or
yes, sir, we can see it. If you can just put a slideshow mode, sir.
Oh, yeah, sure. Is this better?
Yeah.
Now it's all right.
Thank you so much. So I have two parts. One is biometry in atypical eyes and some tips to minimize the errors. So the first comment has to be that we have to thank Dr. Warren Hill for having a wonderful site, drhill.com, where all of us, the students and the practitioners, can update our knowledge about biometry. He takes great efforts and it keeps changing every few months. And although we've all seen it several times, it's worth going back there again. So my first tip is to use the immersion and not the contact ultrasound. And the reason for doing this is very simple. You can see in this particular series of examination, the anterior chamber depth is 4.10, 4.05, 4.29 mm, 4.39, 4.00, 4.05. So the ACD varies from one examination to the next when we do a contact method. And this gives us varying axial lengths. We're all aware that the vitreous cavity cannot be compressed, the lens thickness cannot be altered, but variable corneal compression is the reason why we are getting variable axial lengths with contact ultrasound method. So all of us should follow the first step, which is to move on to immersion scan. So this is a series of measurements taken in one of my patients where you can see here 2.38, 23.48, 23.48, 23.49, 23.48. You can take any number of measurements and they're all grouped together. So the variability that you see with the contact ultrasound is not there if you're doing immersion scan. Till you convert totally to immersion scan, if you're doing contact biometry, please do it with the patient lying down. This is a single important tip that I can give you to improve your outcomes for measuring the axial length. The patient should lie down, hold the probe by the wire. The patient should extend the other hand and fix it at the tip of the finger, and that will keep the eye aligned properly. You can also use a wide speculum if you wish after applying paracaine to make sure the patient does not blink. The next tip is you have to calibrate all your instruments once in a while. In my calorimeter, I find I have to calibrate the ocular end, the eyepiece for zero error quite frequently. The next thing is to optimize the corneal surface before keratometry. Please think of doing biometry and topography when you're thinking of doing toric IOLs. Like Dr. Chitra mentioned in her wonderful and extensive talk, use a validation criteria. For example, if you have a difference of more than 3 millimeters in axial length between the two eyes, it's worthwhile checking all the measurements again. Get to know your instruments and your staff for using them and give them the power to come back to you if something is not perfect. And these are some interesting tips for atypical eyes. We all know that for myopic LASIK, we have to use a negative aspheric lens to compensate for the central flattening of those corneas. And in silicone oil filled eyes, it's best to use a PMMA or a hydrophobic lens. The last is a tip which I learned recently from Dr. Arul. For all keratoconus patients, to get excellent uncorrected distance visual acuity, he uses trifocals. And why does he get such good results with trifocals? And the reason is probably because in keratoconus, we get a hyperopic error depending on the K of the cornea. The steeper the cone, the more hyperopic the error tends to be. So it's easy to get a +2 or a +3 error in patients with keratoconus. If you're putting a trifocal lens, let's say of power 18, you're not only putting a lens with power 18, you're also incorporating a 19.5 and a 21. So you get 3 hits at getting emetropia in patients with keratoconus if you put a trifocal. So this is one interesting tip about choosing the intraocular lens. quality checks are very important. In an autokeratometer like this, you have to look out for those kind of less than perfect dots, which is probably because of mild dryness of the cornea. The newer instruments like Anterion and IOL Master 700 make it very easy for you. They cue you in when something goes wrong, like you have a red dot here saying that you can't take the measurement. And during the measurement, it tends to guide you, it tells you, okay. So it tends to tell you to move the whole instrument to the right, to go back, to go forward. And here you can see the dry spots which are coming on when my assistant asks the patient to open the eye wide. So after the series of tests are done, it also, before it does the calculation, it forces you to examine each value. This we have to do. We have to examine each value and see whether we have a perfect cornea which was measured, a perfect white to white which was measured, whether we have a macular hole like ARMD posteriorly. So by forcing us to re-examine all the data points, we know that it is not a garbage in, garbage out, but we actually have a good quality values which we are feeding into the eye. In this particular movie, we can see the, if you force your patients to just take the measurements and come back, due to pressure of time, they will try to take a K even in an eye like this. But an eye like this will not give you good results. So you can see that how when the cornea dries, when the corneal surface is not perfect, you can have an extremely disturbed mire. So it's very, very important that you give time to your patients and you give time to your staff, and you cannot be taking these measurements after we have dilated them. We should not be taking measurements after we have put paracaine on these patients' eye. We should try to take them on a virgin eye, and we should take time to optimize the corneal surface before actually taking the measurements. So careful clinical examination to rule out problems like EBND and other surface issues, accurate measurement, validation of each step are all very important part. And the doctor, like Dr. Chitra said, should be involved in this process. We all know this old statement by David Chang that patient happiness depends on getting 20/20 at least in one eye. But this becomes difficult in atypical eyes. So this is a typical eye. It's easy for most of us to get the majority of our patients very close to plano in a typical eye. But in an atypical eye, and to understand what an atypical eye is, we have to go back to the seminal paper by Dr. Jack Holliday and James Gills, where they describe the 9 types of eyes. Dr. Chitra clearly showed us that 93% of our eyes are normal, but the remaining 25 odd types of eyes either have a large or a small anterior segment, either a large or a short posterior segment. So this combination gives us 9 types of eyes, and one single formula like SRK2 or SRKT will not be enough to get a good value for all these eyes. So we need to have a suite, a buffet of formula, and we have to use the appropriate formula for each patient. For example, if you're going to have a patient where you're going to do a lens exchange or a piggyback lens, you should choose the Barrett's RX formula. Right in the center, if you choose to use a toric lens, you must use a toric calculator. And if you have a patient who had a prior refractive surgery, you have to use that one on top, prior myopic or hyperopic LASIK, PRK, SMILE, or a keratoconus. So these patients have an altered Gulfstrand ratio, which is a dominant factor which gives you an error. And for them, you have to use the Barrett's True K formula. So you can't have one formula for all the patients. You should choose the formula. Now, Kane formula in the last 2 years there are excellent presentations with large series showing that it is slightly superior to Barrett's. And I think over the next few years, most of us will try out the Kane formula as well as the upgraded Hill RBF formula to see whether our Barrett's is giving the right value or not. So let us come to a few of the atypical eyes. Here is an eye with a small pterygium. It's an atypical eye, but it will be quite easy to take care of this particular patient. Can you tell me how many more minutes I have?
So you have 1 minute.
1 minute, thank you. But if you have a large pterygium like this, which has crossed the midline, my own approach will be to amputate the pterygium, to peel it off, not do a deep scraping and not try to remove all the residue in the central zone, but do a cosmetic clearance only away from the pupil and use the care from the fellow eye for this particular patient. Extreme axial myopia is a challenge, and I will advise all the audience to use an optical biometry or send these patients to a place where an optical biometry is available. If an optical biometry cannot be used due to a density of the cataract and you have a posterior cephaloma, and a vector AB scan can be done. Vector AB scan is easy when you know where the approximate macula is. You can see the optic nerve here, the macula is probably here. But in an eye like this, where the optic nerve is here, it's difficult to find out where the macula is sited, and a vector AB scan also will give only an approximate value. Pediatric eyes are a challenge, and part of the challenge is trying to get measurements under GA in these patients. Eyes with silicone oil are also atypical. Please send the patient to a center that has an optical biometer. This is the best thing that you can do. We know that sound travels slower in silicone oil, so errors of up to 8 millimeters in axial length are possible. In addition, most of our lenses are biconvex or posterior convex, and what happens is the silicone oil convex surface reduces the effective lens of the or effective power of the lens. So we have to add a +2 or a +3 to these lenses to get a better value. We have a rule of 2 when you want to do a lens exchange. If you want to do a lens exchange or a piggyback, please wait for 2 months, and please wait till the refraction is stable on 2 consecutive examinations. Thank you. I think my 10 minutes are up, and I will stop with this.
Thanks a lot, Dr. Ramesh. You did your best to cover a very extensive talk. But Dr. Rohit Shetty is there?
Yes, ma'am.
Yeah, I wanted to ask you, like just now, Dr. Ramesh commented about using trifocals and keratoconus. I wanted your thought that the irregular astigmatism and the challenges, could we make a sweeping remark like that for keratoconus?
Thank you, Dr. Ramesh. Always learn the fundamentals in such a beautiful way. And thank you, ma'am, for bringing the entire overview of the formula. The thing about keratoconus, which I want to say is, you have a hit and miss story. Sometimes you do something, you get it right, and sometimes we assume that that's the way to go, and sometimes we do the same thing again on the same different, you don't get it right. So until unless we have a very strong data, I mean, it's an interesting concept about having different lens concept. I think Dr. Arul must have thought about it in depth too before he started using it. But optically, it depends on where your cone is and where your angle kappa is again, because that's where he's trying to see. And if it's a long-standing keratoconus, each one of them try to find the sweet spot in the pupil. Sometimes you have the cone bisecting the cornea. So if you have a larger series, and if you can, if we all can see how the data is, then it'll be very interesting. As an interesting concept, but we have to really see it in larger numbers. That's my take on it.
Probably, I would say that I'd like to add that you would maybe, I don't know, it could be valid in maybe very early cases, but the moderate case itself, you would need to regularize the corneal topography and then go ahead and do it. And in extremes of cases, it sometimes makes sense to place an aspheric IOS and let the patient wear the
internet off
I think you all should mute Mr. Admin, because there's a lot of disturbance. Namrata, your thoughts?
I think I would agree with Rohit completely on this, because I feel trifocals for keratoconus would be, I mean, we really don't have too much long-term data, and that too, even if you cross-link those cases, we really don't know what will happen to the aberrations, what will happen to the higher order aberrations that are there, and how they will behave, even if you have cross-linked those corneas. So I think that is something to be seen. But having said this, I'm sure Dr. Dorairajan has experience on it, and probably has a series on it. And if he can, tell us about that, would be good. But I don't think there is enough published literature on use of trifocals in cases of keratoconus.
Dr. Tityal, very warm welcome to you. I wanted to know that how does lamellar keratoplasty alter the corneal curvature and how that would affect optical biometry, because that is one point could not be covered in our 10 minutes talk.
I think, lamellar keratoplasty for any, corneal pathology is a very good option, especially if you look into post-ectasia patients. This will really give you a new corneal tonicity and would be a better way to judge these patients. And biometry as such, axial length may not change greatly unless the keratoconus was very, very advanced to begin with. Otherwise, normally it remains same. The only consideration in lamellar keratoplasty also would be the change in astigmatism as the healing process continues, or when you remove the sutures also. So if we have to do some sort of cataract surgery in these patients, it will be better if you remove all the sutures, wait for at least 4 to 6 weeks, if not 2-3 months if possible. Make sure your cornea is totally stable. Then you can have a better biometry for these patients. Only thing, if you have done a manual surgeries or anterior lamellar keratoplasty, then interface comes into play. So that per se may decrease the contrast in these patients. But if you've done a dark, which is a desmetic dark, then it's like a normal cornea. And as far as anterior and posterior corneal curvatures are concerned, there's not much of study to compare normal versus lamellar keratoplasty. But we all know if you've done an anterior lamellar keratoplasty, the posterior corneal curvature change is not much. It is mainly the anterior corneal curvature, unlike in other cases.
But if you have done a DSEC, wouldn't hyperopia get induced because of the posterior corneal curvature? And maybe you need to add, ensure that there is a myopic shift. You induce some myopia in these eyes.
That is true. We normally go for a little bit of change in these cases because you're going to produce a little bit of hypermetropia in these cases. Yeah. But with the DBEC type of surgeries, we don't do any manipulation there. But if you're doing an ultra thin DSEC nowadays, we are doing at least people have recommended 1.5 diopter myopia to begin with the early DSEC surgeries. But now we know, as we see these patients, even you have a 150 micron thickness of stroma in DSEC, within a 1 year, the stromal thickness goes down to almost 50%. So that also shifts your hyperopic shift, which is happening. So we don't go for a 1.5 myopia now. Just 0.5 myopia will be sufficient for a new DSEC procedures. DMEC, you don't have to do any change.
Anaga, you had some questions?
Yeah, ma'am, I wanted to ask 2 questions to the expert panel. One is, in case of a silicon-filled eye, if it's a dense, mature cataract where even optical biometry is not possible, what would you do, especially if it's a one-eyed patient? And second is, if it's a patient who has had an RK first and then LASIK also done in the same eye, then, because I had such a patient and that was a one-eyed patient, so I would like to know from the expert panel, what formula would you use and how would you, what IOL would you use? Dr. Himanshu sir, Dr. Tityal sir, Namrata ma'am, Dr. Rohit Shetty sir. And excellent talks first, Chitra ma'am, Ramesh sir.
Yeah, Ramesh could also answer that.
Yes.
Ramesh, your talk was really good.
I'll just take the question on the LASIK plus the RK. I feel you should go with which was a dominant correction. If it was a minor LASIK done for a major RK, you should treat as a post RKI. Usually
sir,
these eyes, RK, sorry.
Routine 18 cut RK with LASIK with no history, no papers available, sir.
If were both done on the same
eye.
Same time or at different time?
No, sir. RK done first, and then 3-4 years later, LASIK.
So in that patient, you should treat it like an RKI because the RK would have debulked most of the power. So you should treat it like an RKI.
So the problem is, if you consider post RK calculation, you would get a number which would be much lesser compared to the post LASIK eye. Like for example, for post LASIK calculation, you will get somewhere around 23-24. and post RK you would get around 20, 21. So which is almost a 3 to 4 diopter difference. So if you go for the post LASIK one would give you a higher IOL dioptric power. So I just wanted to know from the expert panel, because there would be a lot of difference in the IOL power if you consider either post RK or post LASIK separately.
Right.
Can I
You
answer
cannot
that?
take
Yes,
both in the
Dr.
consideration. You have to choose one.
Yeah, I would look at the axial length very critically. This patient, if he or she has undergone an RK and then underwent a PRK or whatever LASIK, PRK, most likely, that means the correction was either insufficient or the correction didn't take place at all. A lot of times, if the RK was done with 2 superficial cuts, then nothing, flattening would have been very insufficient. If the axial length and the calculated power are kind of something that tells you that this patient's correction with RK was very poor, then you would treat this patient more as a LASIK patient or a corneal laser correction done patient. If the RK gave very good flattening, but it was insufficient, then you would stick with RK calculations.
Just coming, Chitra ma'am, coming to the question what Dr. Anaga asked, I want to ask the panelists here. What we used to do when it's a hard cataract, silicone oil filled eyes, when IOL biometry was not possible. So we can, if the retina is settled, we can definitely take out the oil and we can definitely calculate IOL power with any of the ultrasound method and then go in for the secondary IOL implantation. Most of the time, what we used to do is remove the cataract, remove the silicone oil as well, and then it becomes like any other normal routine patient, and then we can go in for the IOL power and then we can do it. Since it's a one eye, definitely he doesn't mind wearing the glasses because it doesn't have much of asymmetry between the two eyes. But if it is two eyes, then definitely if it's not possible to calculate under the dense cataract and especially under the oil, and sometimes we use heavy silicone oil also, and it will be still more difficult because of the increased viscosity, the sound traveling will be much lesser. So in those cases, I prefer to remove the oil and then go in for a calculation. We can always go in for a secondary IOL power. Panelists can correct me if I'm wrong.
Dr. Anaga, you
Yes,
also have an option of changing the velocity. Basically,
Yes,
the
sir.
velocity is the problem. See, I think you can reset the velocity so that you can probably the correction can happen. So I think in the biometry, we have options. In the acoustic biometry, I'm not talking about optical biometry, we can have an option of resetting the velocity.
You're saying for silicone oil filled eyes, right?
Yes, yes.
Yes.
Even in optical biometer, you can feed in the silicone oil mode.
No,
And
it's a mature cataract. No, it's a
Of
mature
course.
cataract.
But it's a mature cataract and we are
So
not.
that is the point. So the optical biometry is not possible because of the maturity of the cataract. So you can reset the velocity, and that would be probably the best bet compared to all the options available.
I'll just ask one simple question before we move on to our next speaker. Like between multifocal versus EDOF in post laser vision correction. Dr. Rohit, could I have your thoughts?
Basically, everything or all the optically, every lens depends on the shape of the cornea you're in. If your cornea has extremely flattened up, if you're treated a -9, then it's a different concept optics compared to a -2. If it's a -2 treated eye and a well-centered one with no coma and minimal spherical aberration, you can do the multifocals. If you're treated a -8 or 9 and created a tremendous amount of spherical aberrations, and if it's a slighter decentration. So if you're planning anything, it's not just essay. Many cataract, I'm sure Himanshu is going to speak about it. Most of the time, you only look at spherical aberration and decide. I think cataract surgeons should look at other aberrations like coma, which helps you to look at decentration. The spherical aberration many times is forgiving, but coma is not. And when you make an incision, you induce more coma, so that your multifocal becomes. So if you have a very low spherical aberration and a small corrected pre-op, multifocal can be done. But if you have corrected a very high, more than 6, and your decentration is not extremely good, then you can think about the EDOF lenses, which helps to give you a better depth of focus. This is my take optically. I mean, saying that it's completely contraindicated to put a multifocal in a post-LASIK eye, I don't think holds good today, especially with so much of new imaging technologies which help you. So two things helps us: the amount of spherical aberration induced, and the second is the centration of your laser.
Yes, very true. I think there is no second thought on what he has said. It completes the whole question. I think paucity of time, I'm sure there's going to be a whole lot of questions which will be discussed.